Moderator for today's session, and I thank you very much to coming to our session on specialized programs. Thank you to the delegates for all your hard work in putting these presentations together and providing us with their valuable information. Just a quick note, we will be recording this session, just so we will be using a microphone for question and answer period. If you could hold your questions and answers to the end of the session, that would be appreciated, and we'll try to get to everybody. If we can't, the delegates would be more than happy to stay behind and answer some questions for you. So we'll have three presentations today, and I'd like to take the opportunity to introduce Kieran Bergman of the Ontario Renal Network and Dr. Marianne Murray from the Ottawa Hospital Home Dialysis. They'll be doing the first presentation on enhancing the provision of peritoneal dialysis in long-term care through funding reform. And Kieran is a senior analyst for the funding policy at the Ontario Renal Network. So I'm looking forward to hearing about all that we can do in long-term care. So welcome.
Okay, thanks. Good afternoon, everyone. My name's Kieran, and I'm from the Ontario Renal Network at Cancer Care Ontario. So just to give you a little overview of my presentation, if this will work. Oh, there we go. So first, going to go through just a quick overview about chronic kidney disease in Ontario, then through the need for assisted peritoneal dialysis, or PD, in long-term care, then over an overview of the initiative that we're working on right now at the Ontario Renal Network, and then Marianne will go through a clinical example. So currently there are about 10,400 patients receiving dialysis in Ontario. These patients can get two different types of dialysis. There's hemodialysis, in which blood is filtered through a machine to remove waste and toxins, and then cleaned and returned to the patient's bloodstream. Peritoneal dialysis, in which the fluid flows into the peritoneal cavity, dwells over time to absorb toxins and is then drained. And this will really be the focus of our discussion today. Both of these forms of dialysis can be done either in the hospital satellite unit or at home, but PD is primarily done in the home. 76% of the dialysis patients in Ontario are in-facility modalities, and 24% receive dialysis in their place of residence. 18% of these are on PD and 6% are home HD. So there's about 42% of patients beginning dialysis are older than 70 years of age, and they are often more frail and dependent than younger dialysis patients. According to researchers, PD provides a better quality of life than in-facility HD for these patients, and particularly for elderly patients. And that's because it's been shown to enhance autonomy, quality of life, and outcomes for patients with CKD, while also reducing overall costs to the healthcare system through the increased uptake of independent dialysis. Due to a number of reasons, such as those listed here, some CKD patients may not be able to be completely independent on PD, and therefore they may require the support of a caregiver, a family member, or a healthcare professional in order to stay in their place of residence, whether that be in their home or a long-term care facility. So now I'll just go through the need for assisted PD in Ontario. So currently the ministry provides funding to long-term care homes for the provision of nursing support services for those PD patients residing in long-term care homes. This funding is aimed at allowing PD patients who reside in long-term care homes to receive PD support and avoid falling back into in-facility modalities. Currently, only 28 of the more than 630 long-term care homes in Ontario are approved to provide PD services. So this means that for many patients who require placements in long-term care homes, in-facility HD is their only option. And that could be either because long-term care homes in their area are not approved for PD, or they may not have enough available PD beds. Based on the analysis of the available data, there are more than 500 long-term care residents who are currently traveling from their long-term care home to in-facility modalities, whether that be in the hospital or satellite unit, to receive their dialysis. And they travel 3 times per week. Based on ministry data from 2008, costs of this to travel 3 times a week for dialysis is about $10,000 to $25,000 per patient per year. However, anecdotal data that we've gotten recently suggests this can be up to $100,000 per year. So in addition, this travel, as you can imagine, is associated with diminished quality of life and independence for these patients. So definitely something that we want to look at. So this map just gives you a bit of an indication of the distribution of long-term care homes in Ontario. The light blue dots are those long-term care homes approved for PD. The purple dots are those that are not approved for PD, and then the blue dots are the CKD regional programs and satellites. So it just really gives you an idea of where those long-term care homes that are approved for PD are, and you can imagine the populations that aren't really getting access to this care in their areas. So we've identified some major barriers to patients receiving PD in long-term care. First being the process by which long-term care homes are approved for PD. This process involves 5 organizations: the CKD Regional Program, the Interested Long-Term Care Home, the Ministry, the CCAC, and the LHIN. And according to a number of CKD programs that we've spoken with, because of this, all the different levels of approval required, the approval process can take anywhere from 4 months to 2 years, so it can really be onerous and lengthy. Currently, there's only 1 long-term care home in Ontario that has been officially approved to have designated beds for PD, and Marianne will speak to this a little bit later. But what that means is that when a PD patient requires a bed in that home, they get priority status for that bed. So for those homes that do not have this designated bed process, it can really mean that the wait times to get a bed can be extremely long because they aren't given any priority in the placement. The lack of critical mass of patients in long-term care homes, combined with high attrition rates of these patients, really makes it a burden for the long-term care homes to maintain the skill and competency of their staff. So you can imagine if there are no PD patients, a staff may lose their skill, meaning they will need to be trained again once a PD patient is coming into the home. And this can really, again, increase those wait times for patients. So just to give you an idea of what we're doing at the ORN. So since 2009, the ORN has been working with clinical policy and financial experts to develop a framework that links funding to best practice patient care. We're currently in the 2nd year of implementation, going into 3rd, but currently that has really been based hospital-based. So what we are looking to do is to expand that funding framework to incorporate funding for assisted PD where required by patients through the help of long-term care homes or CCACs for care in their home. We are working towards developing a model that aims to reduce the care gap that currently exists for assisted PD patients, improve access to quality care for PD patients, and strengthen integrated care. So this is just a little bit of the work we've been doing to date, doing a literature and jurisdictional review of a number of jurisdictions. We've also formed a long-term care working group that's made up of representatives from long-term care homes, CKD regional programs, and the LHINs. And they really help us. We meet regularly to come up with recommendations. We've also consulted a number of other clinical experts and also looking at the need identified by patients and their families and analysis of the available data, which I'll talk a little bit more later. So the model that we're looking to develop has 3 key principles. The first is equitable access to assisted PD in the place of residence, a shared model of care to improve quality, and evidence generation to inform best practice. So these are some of our recommendations for improvement that we'll be working towards. First is refining the model to improve access to quality care for PD patients in long-term care homes. That may involve having more long-term care homes have designated beds, and then also looking at ways to improve that approval process that I spoke about earlier. The second recommendation is to increase care coordination between the CKD regional program and the long-term care home in recognition that they're both responsible and accountable for those patients. The third is to increase data collection to inform the refinement of the model. What we've really been finding so far in this work is that there isn't a ton of patient and provider level data specific to this patient population, largely because at the moment it is quite small. So we really want to work with long-term care homes to collect more data on these patients. The fourth recommendation is to ensure that reimbursement is reflective of patient requirements and incentivizes care. And that goes really hand in hand with the data collection. And finally, to standardize training for long-term care staff who are going to be providing PD. So those are some of the recommendations that we have at the moment, and just an overview for you. I'm going to now turn it over to Dr. Marianne Murray, who's going to give us a little clinical example.
Perfect, thanks. Hello, everyone. So I'd like to take just a few minutes and talk to you about how do we move the art of the possible into actually operational tactics and strategies. And so in the Champlain LHIN is a very large LHIN which covers a geographical area about 3 times the size of PEI. So we're both urban and rural. It's a large LHIN with multi-population. We really identified a need for both enhancing the community support, but also long-term care support. And so as a consequence of that gap analysis, we brought together a number of key stakeholders. So working closely with our partners at the LHIN, and the regional program, and CCAC, which holds the wait lists for long-term care. We engaged long-term care facilities across the region to see if there was interest in developing PD care expertise and going down the path of an actual dedicated wait list. So we had 2 parties who were interested, and as it turned out, one was in the midst of a capital expansion project, so wanted to wait until that was in hand. But colleagues from Résidence Saint-Louis, long-term care facility associated with Briere Continuing Care, decided to take up the challenge and worked with us. So the message here is it takes a community to do this. So essentially what we did, we came together and we did 3 things. The content expertise around PD care exists within the regional program. So within the home unit, we have the clinical expertise, and we hold the standard of care. What is that black box of best practice in caring for patients who require peritoneal dialysis? So we developed, and we tagged this on with the other project, which was related to developing expertise within CCAC and CCAC care providers. We developed documentation tools, communication feedback loops, and within the home dialysis unit, we use a case manager approach, which in a moment I'll share with you how that actually operationalizes into the long-term care facility. We have a dedicated regional CCAC care coordinator who works closely, and his office is actually associated and beside the home dialysis unit. So with that, we're able to link very promptly, problem solve, facilitate access, and case find in a really timely manner patients for whom this might be a good option. Remember, as Kieran said, these patients are traveling if they need to have hemodialysis 3 times a week. This is a frail, vulnerable population. Imagine what that does in terms of not only their quality of life, but their actual health. So we have the on-site collaboration with our care coordinator. We have a dedicated wait list. So The average turnover of patients who are in our program is about 2 years. So from start to finish, it's about 2 years. If you're on a wait list for 2 years, you're never going to get into that long-term care facility. So it was very apparent to us we needed the dedicated wait list. That took a while to navigate through the channels, and we were really pioneering as we did that. But I think it's a good strategy and an important one to think about how one would want to do this. In the long-term care home, we develop standardized education. So you've got to build the competence and the confidence of those providers that you're going to link with from the home dialysis unit to the actual providers who are on site in the long-term care situation. And we decided we would acquaint our unregulated providers with the notions of what is CKD and what is PD care, but the actual care provision will be done by professional staff. So we identified champions and a standardized education approach with both didactic and hands-on workshop kinds of learning, and as well as reference tools. And then our model is one where we have a identified nurse case manager from the home dialysis unit who works closely with any of the patients who are in the long-term care facility. So we'll be the key point of contact for any questions, problems, issues that are arising moment to moment. But also we'll go and do a formal round, a nurse clinic visit on at least a monthly basis, and then the physician will join her or him on that monthly round, and they will do a whole case review of patients in terms of updating, upgrading, fine-tuning and tweaking, and trying to prevent any further issues from happening. So it's been a successful model. And I just, I'm going to call out to Simon Nakaselli, who's my colleague from Residence St. Louis. He's the director of care, so I'm sure he can share with you as well some of the joys, challenges, and delights that we've had in going through this process. So what's happened to date? We're almost a year old. We launched this about a year ago. We've identified our champions. We've solidified our education processes. As I said, we modeled this project on a successful initiative that we developed with CCAC to enhance our support for patients in the community. We have a dedicated waitlist, and this really is key. It facilitates, it gives the heads up signal. I can call Simon and say, Simon, I think we have a person. We get on the phone, we talk, we figure this out, and within days, we can probably facilitate a smooth transfer for that patient and a smooth transfer for that patient's family. So it's worked very well from that perspective. So we've enhanced that whole system navigation, made it seamless, and we do early case finding in order to identify these folks. Realistically, what we found is patients who are already in a long-term care facility who are on hemodialysis, it's not realistic to expect those patients to change modalities. To actually change to PD means that you have to have a surgical intervention, to have a PD catheter placed. We're talking about a frail elderly population. So what you really need to do is case find early and help that patient and family to identify PD as being a viable option for them so that they can transition smoothly and quickly and in a timely manner into a long-term care facility where the staff has the skills and confidence and the support and resources in order to provide that kind of care. So along with that, we have continuing and ongoing education, problem solving and problem sharing, and it's, as I say, an ongoing collaboration. We're all learning together as we go, and as we approach the end of our first year, we will be submitting a full evaluation report to the ministry. In terms of next steps, we will be developing and completing that evaluation process. It will lead us to perhaps recognizing some key recommendations and help to inform the work that's being done with the ORN, and look forward to engaging all of you in further conversations about what is the art of the possible and how do we make this happen for patients who are frail, vulnerable, and really have a need for this. Thank you so much.
Thank you very much. I found it very interesting.